let me welcome Professor Heaton, who is a backbone for this entire CME, and I'm delighted to welcome Professor Heaton, and he does not have, we don't need any introduction for Professor Heaton. Everybody knows across the world, and he's currently working as a professor of liver transplant surgery and HPV at King's College Hospital, and he led the unit for past 25 years, since 1994. They have vast experience, over 6,000 liver transplants, including 1,200 pediatric transplant. He is one of the pioneer in auxiliary as well as the split and pediatric liver transplant, also domino. So any doubt, anytime, he gives the answer for that. So let me welcome Professor Heaton. And currently, he is doing a research on proteomic phosphorylation for cholangiocarcinoma and hepatocellular carcinoma. So he has published extensively over 600 papers in liver transplant and HPV surgery. Professor, thank you very much for joining us.
Thank you, Raj. Can you hear me okay?
Yes, Prof. We can hear you, Professor.
And can you see the slides okay?
Yes, slides we can see, and we can see you also, Prof.
Great. Okay. Well, listen, I'd like to welcome you all, and I'd like to thank Raj and Srinivas for putting this all together. And so I'm going to talk about allograft dysfunction after deceased donor liver transplantation. What you'll see is the first 5 to 7 days are quite different from living donor, but after that, the two forms of transplantation and the interpretation of allograft dysfunction start to come together. I'll just work out how to. Thank you. So the definitions for cadaveric transplantation are what's now called initial poor function. And those have been well described in the living donor situation, where there's transient clinical and laboratory changes, and the majority of injuries are reversible. It's a spectrum through to primary non-function, but the obvious cases are really very catastrophic. As soon as you reperfuse the liver, you know something's wrong, and it's a catastrophic event. And what you see is a rapid increase in serum transaminases, a persistent coagulopathy, increased lactate levels, hemodynamic instability, hyperglycemia, and multi-organ failure. So this is really obvious and catastrophic. If you look at the series that have been reported over the years, this is one review, you'll see that the incidence of initial graft dysfunction is somewhere between 10 and 30%, and most series will have an incidence of about 20%. Primary graft non-function is much less common. In our own program, it runs at about 2%, and internationally, you'll see levels from about 1 to 7%. Primary graft non-function, as I've said, has a high INR, lactate, acidosis, and pressor dependence. Survival is really only with early retransplantation. And there are multiple causes, the most common being a marginal graft, but occasionally a marginal recipient will tip a liver over the edge. I think surgical complications are often missed. Surgeons will not recognize technical shortcomings. Covert warm ischemia, if it takes a long time to put the liver in and it warms up, that may cause problems. And even with cadaveric transplantation, where you're replacing the whole liver, you can have covert inflow and outflow problems that may influence graft survival in the short or long term. And then the final aspect is anesthetic intraoperative management. And relatively little, I think, has been written about this. but it may contribute to graft early function and survival. Primary graft function, according to UNOS, has been defined with a serum AST of greater than 3,000. Actually, I think that's a little on the low side, because if a patient has a first day AST of 3,000, my expectation is that that graft will survive, providing the patient doesn't get into any other complications. And certainly with DCD, a first day AST of 3,000 is compatible with graft survival. And then the other factors associated with primary graft function in this definition is an INR of greater than 2.5, severe metabolic acidosis with a PHD of less than 7.3, and a serum lactate of 4. I think these are all quite conservative and differ from my experience of primary function, which is much more clearly defined. You'll see in the literature that people have defined primary function in many different ways with different levels of AST, INR, and encephalopathy. The early graft dysfunction, I like the paper by Kim Altoft, where she defined it in very simple terms. She looked at 300 DBD liver transplants. The caveat here is that 58% of the recipients had hepatitis C, so a particular cohort of patients. And for her, the definition was of an AST between day 1 and 7 of greater than 2,000. I think that's a good definition, identifying patients at risk. And those with a serum bilirubin of greater than 170 micromoles at day 7, and an INR of greater than 1.6. And this is in agreement with the French description of the so-called 50-50 rule, which is a serum bilirubin of 150 and an INR of greater than 1.6 at day 5, post-liver resection. These were associated with small for size and patient mortality. So in this definition by Kim Altoft, early graft dysfunction was present in just over 20% of patients. And of these 20%, a quarter lost their graft and 20% died. So this is a useful definition, as Dr. Reddy said, of identifying the at-risk patients that you need to be focusing on and identifying any cause that can be reversed or avoided that contributes to graft dysfunction and potential loss of graft and patient. For the patients who didn't conform to this definition of early graft dysfunction, only 3% of patients had graft loss or death. And the most common indication for retransplantation and death were vascular complications, and particularly hepatic artery thrombosis. And again, there's a wide variety of definitions, and there are some new papers that look at this as well. But for simplicity's sake, I think Altoft's definition is a useful, practical one. So what happens if you've got primary graft dysfunction? Well, in theatre, you'll notice that you get hemodynamic instability. And in the most dramatic cases, you may have cardiac arrest post-reperfusion of the liver. Certainly, you'll notice the pressure requirement is high and is not coming down. But with all these things, you need to be quite patient. You need to try and ensure there's no bleeding and that there's a platform for the liver to stabilize and recover. So over time, you may start to see what are initially very high pressure requirements starting to stabilize and to come down. The most important one for me is the lactate. Is it going up? Well, it will do for a time after reperfusion. But I would say if it's getting to 10 and still rising, you've got a problem there. You need to see, can you sort things out? Is there anything else you can do? So in a patient that you're worried about with early hemodynamic instability, high and rising pressure requirements with a persistent acidosis and high lactate, start hemodiafiltration early, intraoperatively. N-acetylcysteine may help. Actually, I would tend to give it before reperfusion if it's a graft that I'm particularly worried about, a fatty liver with other potential factors for graft dysfunction. Get hemostasis. I think that's really important. Work with the anaesthetist and work as hard as you can to avoid continuous bleeding and the hypertension that often comes with it. Exclude a technical complication. I think, as mentioned by one of the questioners, looking at portal venous insufficiency, it may be quite subtle and difficult to pick up. So measure the portal pressure, and you're really wanting to see a portal pressure between 12 and 15 millimeters of mercury. If it's higher, consider early splenic artery ligation. Again, in patients with severe portal hypertension and a lot of shunting, consider splenic artery ligation before implantation. And then finally, as I say, wait, see if things are stabilizing, and then hold on. You've got to differentiate primary non-function from reperfusion syndrome. Reperfusion syndrome may be associated with an inferior quality graft, but it's usually associated with high potassium levels. Reperfusion of the liver, always make sure as a surgeon you can see the anesthetic screen. Look for bradycardia. Often it's bradycardia that's the first sign that things aren't well with the graft. Start removing the retractors and get ready for massage. And if profound hypertension develops in conjunction with bradycardia, start cardiac massage. If you anticipate this, if you start treatment early with early massage and treat it effectively, you will rescue the patient. There's not going to be an issue here. So differentiate reperfusion syndrome from primary non.